start our webinar. May I welcome you all. Once again, my name is Edward Kataika from the ECSA Health Community. This is our second webinar series. This is our second webinar in the series, organized for the ECSA Health Economics Community of Practice through the support of the Tanzlaonse program. These webinars form part of the knowledge exchange and continuous learning for members of our community of practice and all others interested in enhancing their understanding and capability of health economics. Our topic for today is on health financing. This is a topic that we have discussed previously in the community of practice, but also in other forums within the ECSA region. And I'll not say much, apart from observing that most countries in the region have and continue to implement health financing reforms. The experience has been mixed. In some cases, we seem to get things right, and in others, we have not done so well. So it's important that we continue to share our experiences to avoid repeating the mistakes that we have made, but also to share the best practices from the region and beyond. So we have two speakers today in the webinar, and I will briefly introduce them. The first speaker is Professor Peter Smith. He is Professor of Global Health Economics at the Center for Health Economics at the University of York. His main research interests are in the finance and efficiency of health systems, with a special emphasis on the link between research evidence, and policy. His current interests include health system modeling, measuring and improving health system productivity, and health and universal health coverage. With colleagues, he has published widely on these and related topics, including over 150 refereed papers and 14 books as author or editor. So that's Professor Smith. The second speaker is Dr. Takondo Mwase, and he is a senior health economist with over 25 years of national and international experience in health economics, but also health financing reforms, health systems and services development and strengthening, and health services research. Dr. Mwase has extensive experience in leading, developing, supporting, and managing small and large complex innovative health programs, and providing technical assistance, support, and technical policy advice and consulting services to over 20 sub-Saharan African countries and beyond on health financing and services reforms, performance-based financing, social or national health insurance, health planning, priority setting, resource allocation, resource tracking using the national health accounts and system of health accounts framework, public financial management, economic and impact evaluations, costing of essential health packages, health technologies, equity and efficiency analysis, human resources for health planning, management, development, decentralization, and policy development and analysis. Dr. Mwase is currently working as a health economics advisor on the Tanzlaonse program with the Health Economics and Policy Unit at the College of Medicine, University of Malawi. But prior to that, he worked as senior health economist with Abt Associates. He also worked as a health financing and national health with WHO Regional Office for Africa, but also as a global health leadership fellow with WHO Geneva. And he has also worked as a health economist and planner with the Ministry of Health in Malawi. He holds a PhD in health economics from the University of Heidelberg in Germany, a Master's of Social Science degree from the University of Cape Town, South Africa, and a Bachelor of Social Science from the University of Malawi. So those are our two presenters. And before I call upon the first speaker, just a few housekeeping announcements. First, participants are encouraged to use the Q&A box to post their questions. If you have any question, you can type it in using the Q&A box so that we consider it during we look at it and it gets answered during the Q&A session. Alternatively, we can use the raise hand feature. When we get to the discussion, just use the raise hand feature so that we recognize you and give you the floor to pose your question or comment. And then we also just mention that the webinar is being recorded because we will post the recording on our Health Economics Hub, which is on the Global Health Network. So just take note that this webinar, like the previous ones, is being recorded and we are going to post it on our Health Economics Hub. So with those announcements, let me now invite our first speaker, Professor Peter Smith, to give us his talk on health systems financing. Professor Peter Smith.
Thank you very much, Dr. Kateka. I'm just going to put the screen up for you. Is that visible now? All okay?
Yes, it is up. We can see it.
Good. Okay. Well, thank you very much to the organisers for this very kind invitation. And can I just, before I start, pay tribute to those who've been instrumental in organising this network. I think it's a wonderful initiative. And in my experience, it's these international sharing networks that actually, in many ways, drive forward advances much faster than most other attempts to spread knowledge. So I've been asked to talk just some introductory comments on health system financing. I have to admit that I am have very little knowledge about your specific health systems. I work mainly in Europe, but nevertheless, I hope what I can show is that there are a great number of commonalities between health systems across the planet, and many of the principles that arise in health systems of all sorts are applicable to yours. So what I'm going to talk about, I'm going to give a little bit of background to health system financing. I'm going to focus specifically then on the role of financing in promoting universal health coverage. And I'm going to talk about three challenges that universal health coverage brings. Of course, it brings many more than three, but I'm just going to focus on these three today. And I'm going to end by talking a little bit about what have become known as common goods for health. Many economists would call these public goods, but these are services that are for the whole population rather than for individuals. And I'll come on to talk about them a little bit more at the end, because there's a feeling that they have been neglected in universal health coverage discussions. And of course, the recent pandemic, has brought to light some real shortcomings in some of these common goods. So moving straight on then to the health system finance in general, there is a sense in which health system financing is very simple. It's in a closed system, it's a matter of where the funds come from and who they go to. And this diagram shows the basic flows which exist in all health systems. From the citizen, some of their funding goes via national government through taxes or other receipts. Some of it goes direct to service providers in the form of user charges. And some of it goes to intermediary strategic planners, such as local governments or local administrations or insurers. And the essential thing is that the money has to get from the citizens to the service provider through one means or another. And the added complication in some lower income countries is that there are international donors and other sources of funds which complicate the model somewhat, but they really just represent an additional input into the system, whether it's straight to the national government or to the service provider or to intermediaries. So those are the flows of funds, and most research in health system finance is looking at one of these flows in this diagram. Now, sadly though, there is a shortage of good information on many of these aspects of finance. What I've done here is to draw some indicators from the World Development Indicators, which refer to health system funding, just to give some indication of the variations around the world. So the columns, the first four columns are the World Bank categories of the income of countries: low income, lower middle, upper middle, and high. And then in the last column, I've attempted to take the average, not weighted for population, just the average of the ECSA countries. So health expenditure per capita, I ought to say, of course, just before any of this, that all of this is before the pandemic took hold. And so many things have changed since then. But really, I'm trying to look in the longer term scheme of things. So health expenditure per capita, of course, these vast differences between types of health system. And ECSA, I hope I'm pronouncing that right, actually is at the upper end of the low middle income range in terms of spending. As a percentage of gross domestic product, the second line, again, relatively higher even than the average of upper middle income countries in ECSA countries. So a relatively high high spending as a proportion of the economy in your countries. As a percentage of that total health expenditure, how much does the government support? Well, here we see the usual pattern that as the income of a country increases, the proportion of government funded expenditure also increases. And ECSA 36.8% supported by government. Out-of-pocket spending likewise tends to decrease, although it is actually quite low in low-income countries, probably because of the support from donor countries. So again, ECSA, I think actually is especially low in this respect, at 23% out of pocket as a percentage of total. And then finally, development assistance is just a line at the end of that to indicate how much that supports local health systems. So where does universal health coverage fit into this? Well, it's defined as ensuring that all people have access to needed health services of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. And this, of course, was sparked by the World Health Report 2010. And it's interesting that the Director General at that time, Margaret Chan, said that universal health coverage is the single most powerful concept that public health has to offer. Well, actually, I would argue that universal health coverage is principally a public finance concept, and that it is nevertheless a very powerful tool for improving human welfare, but it's principally about public finance. So that is the link to health system finance is absolutely fundamental. So universal health coverage is principally a redistributive mechanism. Essentially, it transfers wealth from the rich and the healthy to the poor and the sick. And it purchases health insurance for those who otherwise would have very limited cover or no cover at all. So there are two classes of people who benefit from universal health coverage. It secures access to treatments for those who would otherwise have gone without health services. And it reduces the financial cost for those who would otherwise have paid maybe a lot of money for that treatment. And although the priority is the poorest people, it must be universal. It must cover all people to be sustainable. And that's why services must be high enough quality so that all citizens, including the wealthy, are prepared to use them. Because if it becomes a service just for the poor, in a nutshell, and Dr. Mboise may talk more about this, it becomes a poor service. So this is, I'm sure this is familiar to many of you, the cube that the WHO introduced to try and explain universal health coverage. The blue box is how much you have of funds available at this time. And the policy decision is how far horizontally to go to extend coverage of health services to people who are not currently covered. How far, and this goes into the diagram, how far to include services to which they currently don't have availability, so that this is the benefits package. And then vertically, how much cost sharing to retain. And the thing is that essentially health systems only have that blue box to squash one way or another, but the volume of it can't change. Well, I say that, but of course the volume can change to some extent if you can improve efficiency in your health system. I haven't got time to talk about efficiency, but that's actually a universal and really important issue. And it's something that I think deserves far more attention than it has got up to now. WHO estimates that between 20 and 30% of health spending is wasted in most health systems. So I said I'd talk about three big challenges arising from universal health coverage. The first is, of course, raising sufficient funds. The second is reducing reliance on out-of-pocket payments. And the third is reaching vulnerable populations. And I just really wanted to take each of these in turn and just give a little bit of local insight into what's happening. So first of all, total spending. Actually, as I said before, ECSA spends over 6%. It spends more than most categories, on average, most categories, income categories of country, with the exception of high income countries. Hasn't changed much over the last 10 years. I should say that ECSA is, of course, the red bar here. And if anything, it's just slightly declining, but that's similar to most other types of health system, apart from the high income ones. And if we look in detail at the ECSA countries, I haven't put the names alongside this. I didn't want to get to into debates about specific countries, but these are the 9 countries I included in ECSA and their trends over the 10 years with the average in red. And you can see that for most countries, there are a couple of exceptions, but for the most countries, the trend has been quite constant over that 10 years. But the variation is quite substantial. A couple of countries just below 10% of GDP and right down to below 4% in another country. And as I said, what we would expect, in fact, is that as income increases, the proportion, what happens to the proportions of spending from different sources. So, of course, in red, development assistance is likely to decline quite sharply once GDP increases. Government health spending increases quite sharply, particularly once you get into the upper middle income countries. Out-of-pocket spending remains reasonably constant until you get to the high end of this graph. And incidentally, voluntary health insurance, which is this very thin purple band here, is really negligible in most countries, with a couple of exceptions. So the next graph shows government as a percent of total health spending. As I mentioned, ECSA is relatively high. It's been constant across the last 10 years. And if we look at the bottom graph here, we see that, again, the individual countries within ECSA, there's one which is particularly high, but broadly speaking, all the countries are keeping reasonably constant percentage, and it varies between about 15% and about just less than 60% being funded by the government. So the second challenge is reducing reliance on out-of-pocket payments. How is that progressing? This, of course, is a major concern of the World Bank, and in monitoring the progress on universal health coverage, they've produced a lot of work, and much of it led by the late, much lamented Adam Wagstaff. And so this is just one example of some of the material they've produced. This is the incidence of catastrophic health spending defined as 10% of income, and it's the percentage of people who have to spend more than 10% of their income on health services in any year. And you'll see the biggest problems of this arise in India and China and South America. So it's the upper middle income countries which tend to demonstrate the highest rate of catastrophic spending, however you define it. And as you'll see, your region is on this measure is relatively low scoring. And so if we look at the data from the World Development Indicators, out of pocket as a percentage of health expenditure, again, you'll see there ECSA quite low in the mid 20% compared to the average amongst other types of country, with the exception again of the highest income countries. And at the bottom there, you'll see that there are, again, pretty big variations within the region, ranging from 50% relying on out-of-pocket spending down to about 10%. The final aspect, which I think is the most problematic with universal health coverage, is the extent to which vulnerable populations are being reached. And WHO and the World Bank have trouble monitoring this. But they nevertheless produce a service coverage index, which shows the proportion of the population receiving what they deem to be essential services that any health system should be able to provide. And again, of course, the whole of sub-Saharan Africa scores low on this. So it may be that one of the reasons why out-of-pocket spending is quite low is because actually it's really because the price being paid in much of sub-Saharan Africa is the lack of services. I could only find two reliable indicators in the World Development Indicators of this: attended births, where once again ECSA does relatively well on that, and I do notice a substantial increase over the last 10 years, which I can't show you, unfortunately. And then measles immunization, another one which is improving rapidly across the world. So I said I'd finish with just a word about common goods for health, which was in 2019 described by Agnes Suka as being a blind spot that persists in universal health coverage. And these blind spots pose substantial risk to human health and economic well-being. I don't think she realized quite how much she was foretelling something that was going to happen within 3 or 4 months of her saying So what are common goods for health? Well, sadly, the definition is rather garbled. It's probably put together by a committee. But it's essentially what economists would call public goods. So they're population-based functions or interventions that require collective financing. And their two characteristics are that they contribute substantially to human life and economic progress. And there's a clear economic rationale for interventions based on market failures. So either they're public goods or there are large social externalities. And I'll give some examples on the next slide. These were the 5 categories that WHO developed in this project on common goods for health. So they include policy and coordination, which includes preparedness for pandemics. But of course, there are many other aspects of policy. Taxes and subsidies, regulations and legislation, important aspects of common goods. Also information collection, analysis and communication, a very central aspect. And then population services such as sewage treatment and vector control. And the important issue is that these are not goods and services that individuals on their own can provide, purchase, or goods and services that will be provided by the market. This has to be a government function. And they are perfect candidates for inclusion in the UHC benefits package. So all citizens benefit from them. For example, disease surveillance. You can't leave citizens out of that. It benefits everyone. There's very little scope for out-of-pocket charges because these are public goods. And many of these are highly cost-effective. WHO estimates that putting many in place is really trivial in costs relative to the benefits they give. But there are barriers to them. The evidence base is weak. Perhaps most importantly, common goods for health are politically unattractive in being given priority compared to personal health services where people can see the benefit immediately to them and their family. And some of these common goods for health require action at a regional or global level. And of course, that's where organizations such as your initiative may become very important in pushing for this. So I hope that gives a vague outline of some of the issues that are common to all health systems across the planet. Health system finance is a core issue in all of these. It is, if you like, the oil which keeps the health system moving. And it really needs very, very careful attention to ensure that our health systems are strong, efficient, and effective. So if I could now then hand back to the chair, Dr. Kataika, thank you for your time.
Thank you very much, Professor Peter Smith, for that presentation. Just to remind participants that if you would like to pose a question, you can post it in advance using the Q&A panel so that we consider it during the discussion. Alternatively, you can just raise your hand when we get to the discussion. We will now move on, and I would like to invite the second speaker, Dr. Taekwondo Mwase, to give us his presentation. Taekwondo.
Thank you. Thank you, Dr. Kataika, and everyone else on the panel. I'm going to present on the health financing policy reforms for UHC in the ECSA health community, the experiences we have had. So I have a question which is still too far to reach. Is it still too far to reach? So we will see what has happened, and I'm building on the presentation by Professor Smith. Now we are narrowing it down to the ECSA region. The overview of my presentation, I'll have a background, methods, results, key lessons learned, and conclusion. The background, it has been a long journey which has been there and has been stated equivocably by the WHO, say the provision and access to health services to all citizens is a long cornerstone of modern health financing systems around the globe. Here in sub-Saharan Africa, this was soon after independence, where the countries introduced free health services. These were aimed at increasing equity. However, there has been an increase in disease burden, growing demand for quality care amidst worsening macroeconomic situation and influence of international organizations that led to the reversal of the free healthcare policy in most of sub-Saharan Africa, except some 2 countries in ECSA, such as Malawi and Mauritius, which resisted introducing user fees nationally. However, this reintroduction of user fees, after several studies, an agreement was reached that it was really affecting utilization of essential services, especially among the poor, was a major threat to achievement of UHC goals. That's the motivation now among ECSA health community member states is to identify and prioritize health financing policy reforms so as to achieve UHC goal, especially that one of financial protection, which reduces the out-of-pocket spending and increase equity in health services utilization. Currently, inadequate information available on the experiences with different health financing policy reforms across the ECSA health community region. Hence, this study. This is just an overview of the ECSA health community member states, similar to what Prof. Smith showed earlier on, but now I'm zeroing in on some of the issues, such as the poverty levels, because my topic is really touching on how we are moved, the relationship sometimes when you look at the poverty levels and we look at the out-of-pocket spending and the government expenditures and how those and the services, how they're affected. So you can see, if you look at the table there, you will see where Mauritius stands, the column for Mauritius. Then most of the countries I will talk about in where the reforms, the experiences have come from, it's Kenya, Malawi, Tanzania, Uganda. That's where some of the reforms I'm going to talk about have come from. So I go to that. My methods for this study, it was a scoping review of published and gray literature, studies which started around 1997 to around 2020. I had also telephone interviews with selected health financing policy experts and analysts. Data analysis, the theoretical framework, stroke analytical framework, it was the WHO framework of health financing function, the one which talks about the revenue collection, the pooling and purchasing. To expound this, I had to use two other frameworks to make sense of what is going on. The mercantile framework of 2007, which talks about the evaluating a financing mechanism or financing policy or anything proposed for revenue collection and pooling in terms of feasibility, equity, efficiency, and sustainability of the financing, of the proposed financing policy. Then I also used the Watt and Gilson framework of 1994, which is the policy analysis triangle, which looks at the process, the actors, and the context in which a policy was developed or implemented. In this study, I looked at two functions of the financing, which are revenue collection and pooling. And on that, much as I dwelt on other issues, but in this presentation, I'll only look at two. One was the removal of user fees in public mission health facilities. This was one way of reducing out-of-pocket and impoverishing health expenditures. And another one is the design implementation of social/national health insurance in some of the ECSA member states, with mainly national health insurance, which has been introduced for some time in some countries. So what are the results? User fees removal in public and mission health facilities. I'm going to give the examples of where this has taken place. Is Kenya, Uganda, Zambia, and Malawi. In terms of, if I use the policy analysis triangle, in terms of process, if you look at that, it has been in haste, policy inconsistencies. Sometimes there's been withdrawal, suspend after you start, then reintroduce, then reduce the fees, then complete removal with no prior preparation. This has led to some challenges, including deterioration of quality of care. In terms of actors, the international organizations have played a very big role in influencing the countries in ECSA to start or adopt user fees, to adopt in some of these financing schemes. There have been the issues of MOH and development partners. These international organizations, mainly the World Bank, which has been very famous from the 1987 Agenda for Reform. Then sometimes these reforms in user fees that have come from the highest office, especially the field introduction has been through these international organizations, but now the removal has been very much influenced by some development partners and from the highest office, the presidency. In terms of context, it has been, yes, the introduction has been justified in terms of economic crisis, but the removal has been more because of election campaigns and sometimes after adoption of reforms to health financing service delivery, such as the implementation of sector-wide approaches, where now partners have said, no, we need to also think about how we reach the poor so that they can continue to access services. So far, what have been the results? User fees, removal in public and mission health facilities in Kenya, Uganda, Zambia, and Malawi. Malawi, for example, is a special case. It has a free public health care. It has had from 1964, but around 2006, because of the mission facilities which still charge fees, now they took a decision to at least subsidize that care, especially for maternal and child health, maternal, neonatal, and child health. While Kenya has had user fees, this is where we have had removals, reintroduction, reduction, then total removal, especially at primary health care levels. The same with Uganda and Zambia. Impact on the poor is mixed. Equity in utilization, if we take it from the utilization point, increase among the poor only in Uganda is where it has been reported, and not in Malawi, Kenya, and Zambia. Catastrophic, impoverishing expenditures, especially among the poor, no impact, still high. Kenya, Uganda, Zambia, they have all exhibited the high out-of-pocket expenditure, which are impoverishing the population if we take the 10% cutoff point of the income. Issues, what is it that is really not making things to happen? There have been continued charging of unofficial fees, non-availability of funds to pay for the free care, continued poor quality of care, remaining long distances to health facilities in rural areas. These are some of the reasons which have been given in these various studies that I've looked at. In terms of insurance, which I can say national health insurance, the experience in Eastern and Southern Africa, especially in the ECSA community, is more with this type of reform in Tanzania and Kenya. In Kenya, where it all started, as early as around 1966, is when they had the Kenya National Hospital Insurance Fund, which is slowly now being changed to represent like a national health insurance scheme. It was mandatory at inception, starting with all form of the goals appear to be different with these two. I'm comparing these two because these are the only well-developed like schemes in the ECSA region. So it's like starting with the all formal sector workers, though it excluded civil servants at that time. The Tanzania one was voluntary from inception, started with public sector employees only. However, both schemes were not really, did not have the formal registration, parliamentary formal registration, and without a goal of universal coverage at inception. Now, if I apply the mercantile framework, looking at feasibility, there's a huge concern. The studies are showing that failure to increase coverage through use of voluntary approach to informal sector employees, the poor, coverage remains low in Kenya. Of the poor, about only one in the informal sector, almost about 1% or so as of 2018. In Tanzania, it's about 7% of the population and less than about 1% of the informal population. By 2017, in terms of equity in financing and utilization, especially in access, both appear to be inequitable. Inequities in financing, the premiums of civil servants paid for by government, and that is the inequity in financing, and access to benefit packages. They have different packages. The civil servants have access more comprehensive benefit package that's in the NHIF. Inequities in access to benefit package in the Tanzania National Health Insurance Fund, the civil servants and private sector members access a more comprehensive package than the community health fund members. However, in Tanzania, there's an issue of like equity, the civil servants and the government, they each contribute 3%. In terms of equity again, in terms of pools, the pools, there are separate pools in both Kenya, as I've alluded to. Then in the National Health, in the National Hospital Insurance Fund in Kenya, civil servants, they are from 2012 to 14, the poor have also been included through a targeting system paid for by government and the list of the members. So these are the informal sector. In Tanzania, there are civil servants, private sector and community health fund members. Of course, there are issues to do with the targeting that was used in the Kenya National Hospital Insurance Fund to include the poor. The targeting had so many challenges of leakage. Almost 2/3 of the members who were regarded as poor were belonging to the two upper quintiles. In terms of efficiency, both have been found to be inefficient. When I was looking at it, high administrative costs, over 20% compared to 4% for internationally for similar schemes. In terms of sustainability, both appear to be unsustainable. The delays in the premiums after 27 years in 2015 in Kenya, National Hospital Insurance Fund is still considered unaffordable by majority of the members. Rising expenditures and claims ratios worsening in Tanzania as well, which if it continues, Lee and the colleagues, they are saying that by 2025, it might go bankrupt. So what are the key lessons we are learning? From the literature I've reviewed, it looks like removal of user fees in public mission health facilities requires alignment of political directives with financial and technical capacity. This one is because the directives come, but there has been no plan to say, how do we sustain the quality of care? So as a result, the demand has increased. However, the supply of services has been reduced. This was evident in Uganda, where soon after abolition, yes, the poor benefited, but now there was a reduction even from the increase, even by the poor in the private sector. Both the poor and the rich went to the private sector. Despite removal of user fees, low health services utilization, catastrophic and impoverishing payments still remains among the poor. Expansion of national health insurance schemes using voluntary approach to the informal sector and the poor appear to be unfeasible. This was the expansion strategy for the National Hospital Insurance Fund, that they will use the voluntary approach. However, now it looks like it's not really expanding the coverage with the insurance scheme. And expansion of population coverage in national health insurance scheme to the poor it appears using an investor-less approach rather than targeting is the way to go, as targeting faces serious challenges. The targeting also faces the challenge of leakages, which I've talked about earlier. While the investor-less approach, this is where we need to use public resources to pay for the insurance of the poor, which has been happening in other schemes outside the ECSA region, such as those in Thailand, such as that in Thailand. Having multiple pools is both inequitable and inefficient, as we have seen, because of the administrative costs, and again, they raise all these other issues whereby there's no cross-subsidization and the like. So what next? We still have a lot of work because the research, this scoping review shows that we need to understand the long-term equity or fairness in financing and service use among the poor. This one is something which we really have to look at, because is that removal benefiting the poor? Or is it benefiting the better off? It's not yet coming out clear, so we need to dig deeper into that. Effects of user fee removal on workload of health workers, quality of health services. This has also not been well studied. It needs to come out to say, what is the impact? Where we need to learn more about what happens when we have free healthcare services on the workload of health workers and quality of health services. Third, there's an issue to understand about existence and magnitude of unofficial user fees after user fees abolition, or when you have free healthcare system. What is the, really, do they exist? When we do studies like the National Health Accounts, you'll find that in countries where you see that user fees have been abolished at health centers, or there are no user fees, you find that households are reporting to say we paid, but to whom they paid those monies, it's not clear. And any National Health Accounts report, when it comes to financing agents to provide and you take out of pocket, where did it go? It even goes to to facilities, in public facilities, which do not charge user fees. But this has not been systematically studied to say at that level, what is the extent of that? And what is the extent of, does it really exist? And what is the extent of that? That evidence is still lacking. Yes, it is there here and there, but we need to do more. The feasibility of social health insurance in achieving UHC in situations with large rural sparse population, with a limited choice of providers, long distances to health facilities, large informal sectors. Yazbek and colleagues, and they have come up with a commentary in 2020 to say, to them, they are even saying, in our countries, we don't need the tax-based approach to funding universal health coverage, such as social health insurance, the one which is employment type of tax based. But this is an area we need to dig deeper again. Appropriateness of using government tax revenues for paying for premiums of civil servants in situations characterized by large poor populations. McIntyre in 2013 raised this concept to say, there is this, because when we look at our countries, we see to it that those who are in the civil service are much better off than the rest of the population. So is it fair? Is it equitable so that the government pays for these people who are seen as better off than the rest? So this is an area we need to understand better, because some countries, as I'm talking today, just a few months ago, have again within the ECSA region, one country has introduced what I can call an insurance for civil servants, while there is a free public healthcare system. So these are the issues we need to study more. Another issue which comes up is the feasibility of extending coverage to the informal sector and the poor using a voluntary approach. This one was also raised by McIntyre, but it is also there in most studies. So it has also to be understood to say, if we are taking this approach to achieve the financing for universal coverage, is it really a feasible approach of voluntary? Because Kenya, when they tried to use the voluntary approach, the same in Tanzania, the coverage is not expanding because the informal sector have so many other issues. But we need to understand more, is it really a feasible approach, or we should go for a universal approach? So again, it faces the challenges which we have to study. So the last point is the challenges of targeting as compared to universalist approach in health financing policies. Let us see the pros and cons as we go with our financing reforms in Africa, in ECSA region. So in conclusion, the experience of ECSA Health Community region shows that health financing reforms for achieving UHC have been ongoing for decades. Much as each country's context and the identified reform is unique, valuable lessons could be learned through generation and sharing of evidence, what works and for whom, among others. Then sharing of experiences on successes and missteps could aid the ECSA Health Community member states in navigating the potential complications in implementing health financing reforms for universal coverage. From what I've said, from what I've reviewed, it appears it is still too far away to reach UHC goals, especially with financial protection and equity and utilization. As such, further research for innovative financing policies need to be pursued vigorously in the ECSA Health Community region. I thank you very much for your attention. This paper, the full paper, can be found. It has been published on the was Center for Health Economics website, University of York, and it was meant to be a policy brief for policymakers in the ECSA Health Community region. I thank you all for your attention. Thank you.
Thank you very much, Dr. Takondo Mwase, for that presentation. That's a review of the health financing policy reforms in the ECSA region. Very interesting indeed. Dear participants, there we are with the two presentations on health financing. We will now go to the discussion or question and answer, and I will request Paul to moderate. I'm already seeing that there are some more hands, but I think Paul will moderate this discussion. So may I hand over to Paul for the discussion, please?
Okay, thank you, Edward, and thank you to our two speakers for a really fantastic presentation, providing us lots and lots of food for thought and insight. So I can see a couple of hands up already. You are able to ask questions either through using the raised hand feature, if you're happy to deliver your questions verbally, or if you would be more comfortable, there's also the question and answer box where you can write typed questions. So if I could start by going to Dr. Collins Chancellor, if I could ask the when you deliver your question, if you can introduce yourself, say your institution and your country, and then the speakers will respond. So over to Dr. Chancellor.
Okay, my name is Collins Chancellor. I work for the World Bank. I'm a senior health economist, and I cover Zambia, Malawi, and Uganda. So I have a question for Professor Peter Smith. I very much like this presentation, but then I was wondering if there's any room for financing resilience and sustainability, because the presentation, of course, it did touch to some of the emerging issues when it comes to infectious diseases and the like. But even before the COVID, we've seen a number of countries, for example, my country, Zambia, where the government has contracted a lot of debt, and that has suffocated health financing. And with the COVID-19, the situation has worsened. So I don't know how we could actually configure health systems and health financing to be able to make more resilient health systems and more sustainable financing. And just a quick comment to the presentation from Dr. Mwase with regards to user fees. I know it's good to talk about user fees, but then if you look at the experience, for instance, in Zimbabwe, you notice that even when the services are free, when the government was not able to provide services, the communities themselves made sure that they mobilized monies and started, charging user fees so that at least that service is available. So from that perspective, when the government is not able to provide, we've seen this in communities where they mobilize themselves and then they charge themselves because they need that service. And looking at what is happening in countries like Zambia, you expect that it will be difficult for the government to provide services, especially from the supply side. So my question is that should we still look at user fees as a bad thing, or is looking at it from the demand side? Because even when services are free, like you have demonstrated, the supply is not there, right? So which means that we cannot provide. And then it forces households to go and then buy these drugs from out of pocket and the like. So what do you think about that? Because my thinking is that we need to be more systematic and realize that these things are, prepayments are prompted by the inability of the government to provide. Over.
Thank you, Colin. So it's two really interesting questions there. I can maybe ask each of the speakers to speak in turn, although one question was directed to Pete and the second to Takondo. I'm sure both of you will have thoughts on both of the issues that Colin's raised. So Pete.
Yeah, thank you very much, Paul. And thank you, Collins, for very interesting observations and questions. Actually, first of all, can I just pay tribute to Takondwa's presentation? It really was very insightful. And I think the conclusions that he draws are very, very similar to the sorts of conclusions we've been finding in Eastern Europe and South America. So, you know, these are universal issues, and, you know, it really is useful to have them put in such a clear context. So Collins, your question on financial sustainability, I think this is a really serious issue. In fact, it's been a major issue in the European region, where the concept of resilience, health system resilience, has received a lot of attention. I'm not entirely convinced it's been well thought through, but there are some publications on the website of the European Observatory on Health Systems, which address this issue of resilience. And I think it's one that really needs much more careful attention by health system planners. I think, for example, one could envisage, rather like the national health accounts, but they are static. Why don't we start having a, if you like, what an insurance company would do to say, look at the trends in revenues, the trends in needs in the country, and produce an actuarial assessment of the future shortfall in funding, or indeed surplus in funding in the country. And I think that I could envisage that being something that could be developed so that we get some metrics on sustainability. But can I just conclude by saying, I think the core to all of this is the health benefits package. I think many countries have run into difficulties because they've been unwilling or unable to really decide what it is they are able to provide and prepared to provide universally to their populations. And many of the systems that have run into difficulties, it is fundamentally because of that. So I would commend the work that's being done in your region on the health benefits package, and I would urge countries to expand that. And if you look at countries that have done that successfully outside of your region, like Chile and Thailand, they started quite modestly with what they felt their system could afford at first. Chile started with 64 procedures, even though it's a relatively wealthy country, and it's just progressively increasing that number as it gains experience, as it gains more revenue, but it makes sure that it is actuarially, in an accounting fashion, it is sustainable. So, of course, there are always going to be shocks, and shocks are a distinct problem that that need separate consideration. But I think looking at general trends and the match between what is being offered and what is the revenues that are coming in is something that all countries should have a pretty standard approach towards. Thank you.
Thanks, Pete. And Takondwa, could you possibly respond?
Yeah, thank you very much. My answer to that question to say, should we say, look at user fees as bad, given the situation you have described? One would say, tempted to say, yes, if it is paid for by the poor, because the UHC principle, much as it says, it doesn't say we should have free care, but when you look at it, it says who should be covered first? Or in the population, you look at the population, who should be covered? So if these people are poor, then they have to be paid for from the pooled funds which government has mobilized, and it should pay for their services, for these services. This is fundamental point we should all remember to say, look, that's why the issue of priority setting sets in as in connection to what Prof. Smith has said about the benefit health packages, to say, okay, these benefit packages, what should people not pay for? For example, this is where most of our countries in the region, they have tried to design these benefit packages to address almost the same things of like the linkage between financing and service delivery. So if we look at that to say, look, we have the population, these are the poor, which population should be covered first? The number one vote should go, the poor. These poor people, the poor should be benefiting from these services. If they pay direct out of pocket, in which is catastrophic, then it's bad. One which is impoverishing is worse. So this, we should all agree to say, look, this is an unfair system. But now, after we have done that, if there will be user fees for a group of those whom we say they are better off, or for non-EHP services, this is where we should be saying, let's find a way of saying, okay, how do they pay for this? The non-poor or those who are well off outside the sector, or a service that is outside the EHP, should it be paid for through the out-of-pocket? Or maybe this is where we should be talking about how we pay with private insurance. Where the tax-funded system, really we should target it to those who are most in need. So I would say that is the way we can link service financing and service provision. And again, the principles of UHC to say, we have to look at both the idea of saying who should be covered first. Then we progressively move. These ones should not incur, if it's the poor, we have agreed as a nation to say we need the poor to be covered, then let us focus on that. The other issues you have raised is because really, when you look at it, when we leave the poor on their own, it shows now government's failure to make sure that those services are available to these vulnerable groups. So this is the question we should be saying to say, whom do we work for? The UHC is challenging us, the principles of UHC, to say, look first, which population should be covered, with which services, and what proportion of out-of-pocket costs should be paid. It is not saying services should be free, but it is clearly saying the proportion has to be smaller, such that it doesn't push someone, it is not catastrophic, and it doesn't push someone into what? Poverty. They are already in poverty, but it should not push them deeper into poverty. So as long as we are maintaining these principles, I would say, yes, if it is paid by the poor, we are unfair, we are not just. It is something that has to be limited. We need a limit to that. Thank you.
Thank you, Takon Ruiz. Issues of huge magnitude and importance. Raised some fantastic points. We have a question from Henry Kantembe. Could I ask you to ask your question, Henry, and also please introduce yourself?
Okay, thank you very much. And let me just begin by saying that the information presented by both is extremely helpful and, significantly factual. So there will be no questions I'll ask. I'll just make a few comments, especially because I've been involved in health reforms, health services planning for quite some time now. What I do know myself, I'm from Zambia. I'm Director Planning, Minister of Health. I take myself to have some knowledge in health systems. One point I want to make is that for countries like Zambia and countries with similar socio-economic conditions, the best modality for financing health services is through taxes. The reason is, like in the case of Zambia, I believe, even in the countries with similar socio-economic situations, is less than 25% are informal employment. We may dream about capturing the informal sector they're unemployed, but normally these are very futile attempts. They never lead to any successful story as far as I know. However, that said, it's quite possible that we can think of an insurance program which is a complement, which is complementary to funds coming from the Treasury. And this would target now that section of the population, because what is apparently the case is that in countries like which are poor or low income or middle income, the Gini coefficient as we know it, is extremely telling us a story that income distribution is very bad. There is a section of society within a country like Zambia that can manage to pay for services. If we give them a good incentive scheme, why they should contribute, while the rest of the population are actually accessing those services free of charge. In the case of Zambia, I can talk about waiting time before you see a provider. You see a doctor, you see a nurse, and maybe hotel facilities if you are admitted. There's a whole range of incentives that can be offered to ensure that we still have an insurance program which is running, which in a sense can even contribute to improving the primary healthcare services which are being provided free of charge. In the case of Zambia, primary healthcare is free. In our last household expenditure survey, our out-of-pocket was less than 14%, which is the kind of it's okay in my view. The problem is whereby it's normal in terms of quality and coverage of services. These are the things that impact negatively on UHC. Not so much that we drive people into catastrophic expenditure, because that is not the case. In fact, many people die in homes, basically because maybe the facilities where services are offered are very far away, and the small percentage of the population in the formal sector, which is about 20%, there's a small possibility of being driven in this direction. But as far as I know, it is insignificant. So what we must emphasize, governments in our region, Sub-Saharan Africa, must base their financing modality on taxation and being able to allocate a good percentage of national resources to healthcare provision. And then in terms of quality of services, in terms of, they can create an incentive scheme for people to belong an insurance scheme, whereby, that can even cross-subsidize what is coming from the Treasury. That is what the case is. So this will be my comments for now. I submit, Chair. Thank you.
Thank you, Director Kansembe. Really interesting points, particularly drawing from your own experiences and providing further thoughts beyond those that the presenters gave. I wonder if I could ask both Pete and Takondwa to offer responses. Pete, would you like to go first?
Sure. Sorry, I'm just struggling a bit with my computer. Yes, thank you very much, Dr. Kansembe. I think those are very well-made points. And I think particularly this issue, it's not just that the tax base is currently small in many countries. It's also that it's highly skewed to a small proportion of the population. And if I can just, and I'm not sure I've got any real immediate insights into solving that, but I think it is recognized as being a major problem. And so, for example, if you look at India, there they've introduced a national insurance scheme to which, and the people who qualify, the poor who qualify for that, are designated as being below some poverty line, and that is the and so it's effectively a sort of income tax for those who are not below the poverty line. But the real problem with that scheme is that the definition of whether or not your household qualifies for free insurance depends on a very out-of-date survey, which was potentially not at all accurate. And so I do think that in general, middle and a priority for middle and low income countries is to really try and increase the formal tax base, because without that, the sorts of problems that Dr. Kansembe has been describing are just going to be very hard to solve. So I would suggest that actually it's the reform and the formalization of a national tax scheme. And I really do acknowledge that this is really, really hard. But it seems to me that that should be a priority for maybe some of the global agencies, such as the World Bank and the IMF, to really help with developing that capacity within countries. So maybe if I could hand over to Takondwa, maybe he's got some more specific insights he can offer.
Thank you. Thank you, Peter. Mr. Kansembe has really, I can say, summarized some of the issues very well about the situation in our countries and in Zambia. In regard to the issue as that, yes, it comes up to say if we go for taxation, it's a mixture of sources of funds, which we have, then at the polling stage, how we poll. But where I would like to comment more is the issue when we look at why countries like Zambia, Tanzania, Malawi experience, if you look relatively to say, why do we have lower out-of-pocket spending as a percentage of, say, total health expenditure? You'll find that most of our programs in these countries, Kenya, Malawi, Tanzania, and Zambia, and partly Zimbabwe, very partly you find that major contributors are donors. So, and donors are funding those programs which are very critical in terms of like public health goods, and with not very much into curative care. So you see that balance, that when you look at it, where does this money, but that when we are looking at in percentage terms, in relative terms, you find that because they are contributing more, it reduces the amount which you can say this is oops. But if you take them away to say, maybe let us be looking, one day we should be looking at only maybe curative care and the like, then you'll find that households are still contributing, and several studies are alluding to that. By, for example, in Zambia, the Masie group is also talking about how, yes, we have abolished fees, but the studies are finding that the catastrophic spending is there. So the issue of proposed to say, how do we move forward, is what I can agree with you more. I cannot agree with you more because you are saying the very truth. Say, let's have a system. The involuntary one has several challenges, but if we can have a system whereby the identified group, apart from taxation, which it should be the main base, then this group has to be paid for from government revenues. This is the path that in Thailand went through, that those who were poor were identified. But now it comes with the problem of identifying the poor in our societies. This is one of the issues Kenya struggled with when they tried to do that, to say, let's have the informal sector pay on their own, but the poor, let's pay for them. Let's have this so that they are insured. But they found themselves that there was wrong targeting. The upper group gained entry into the what, and still the poor didn't benefit. So these are the challenges we should really work with. So it is something you have really touched on it to say, we need that. We need public financing, or we need a scheme, say, whether it's for this other group, but we should be careful learning again from South Africa as we develop insurance systems. We should be learning a lot again from what is happening in South Africa, that you find that those who are insured, who are 16% of the population, are responsible for 80% of the expenditures in health. So how does that happen? And those 80% of the expenditures go to the private. So we have this situation. That's why we need to, as we design these insurance schemes, or we can call them such for different groups, we should be worried to say, we have somewhere to learn from. South Africa provides a very good example. That's why now they are moving to say, let's have a national health insurance, because these insurance groups of saying this group, if they're interested, this has led to serious inequities in financing and utilization, which they're now saying, no, let's change the way we finance health. So much as we look at different ways, we should at least try as much as possible to be avoiding creating a group which is affluent, can say we can go for this, we are okay, we can pay for ourselves. In the end, we'll move ECSA to again to believe we have to learn from South Africa. Do we want to become another South Africa, then later on change again to say, no, this has failed. Maybe let us turn the tax system, strengthen the tax system, let's go the NHS way. So this is something we should really consider as we move. That if we are talking of insurance, we should have a universal type of approach from the way to go, like the way the funded system was, to say, our goal is to reach everyone. How we reach everyone? We are going to have these steps. Thank you.
Thank you, Takon. Very challenging issue, of course, which combine both evidence, concerns for efficiency, and also, of course, value, understanding of value equity across society. So we have a question in the Q&A from Kingford Chimwembe. Kingford, if you'd like to ask your question yourself, please feel free to unmute your microphone. Otherwise, I can ask this on your behalf. Thank you, Kingford.
Okay. Well, my question is directed to Dr. Mwase. Considering that even where user fees have been removed, the poorest who are supposed to be accessing these services are actually not accessing them. So is it then possible for us to achieve universal health coverage, considering that there are these other factors that seems to be impeding the process? Thank you.
And Takon, just to make you aware of time, I think we've got about 3 or 4 minutes left. So perhaps if you could, fairly brief.
Thank you very much. The answer is like, let's work holistically. The issues I alluded to, you are very right. We have very serious demand constraints. For example, you can remove the user fee at a facility, but if the quality that side has not changed, it is not attractive to the people. But even these people, to appreciate, they have their own issues from the demand side. You have the issues of distance. You have the issues of elite class, which you have to deal with when it is among the poorest, especially the lowest income quintile, the 20% or the 40% below. So let us work on both sides. So now some of my issues I've been saying, or maybe trying to figure out is, should we now reach a point where we should be thinking of conditional cash transfers so that the poor can have access to, you condition it on education, to say if you access education, this is what we pay for you, so that there's a literacy appreciation of modern health services. If you have some money, you can have some money for transport, so that they can at least now begin to see they can have children who are nourished, so that at least they can, you give them those indicators, so that you feed your children well, this is what we should do, so that they don't even get sick more often. So this is somewhere maybe we should be now taking the debate to say, okay, we have tried to deal with the supply, let us also deal with the demand side concentrates, so that together, while the supply also should work on how to make services available, reduce the corruption, improve allocation of resources. So we should be working in sync, the supply and the demand side. Thank you very much.
Thank you, Takon. Edward, I can see your hand is raised.
Yeah, thank you, Paul. I think Takondo has partly addressed what I have, but what I wanted to say here is, you know, listening to Takondwa's presentation and the discussion this far, and of course also from my knowledge of the ECSA region, you know, these reforms, they seem to have been designed and implemented in a piecemeal and haphazard manner. Somewhere you see that maybe there was some element of trial and error, and as Takondwa did mention, the impact has been mixed. Now, are the health financing strategies the way to go? I know a number of countries in the region are now talking about developing health financing strategies where you are looking at, you know, these reforms, looking at packaging them very comprehensively with a deliberate, you know, goal in mind to say this is what we want to achieve. Of course, I'm aware that having a strategy is one thing and implementing it is another. But looking at the reforms holistically, and say with a deliberate action towards achieving a certain goal, is this the way to go? Of course, I mean, this is a question to the panelists, but it would also help if we get a comment from the colleagues from the ministries or the other panel, or the other participants. Yeah, thanks.
Thank you, Edward. Could I, very honoured to have three directors of planning on the call, in addition to Dr. Kansembe. We also have Director Jibril from the Gambia, and so I think Madame Tiene from Senegal as well. So it would be nice to ask this question to the Ministry of Health director, in particular, whether health financing strategies is something that you're looking at and you feel will be valuable and useful. So any quick responses to this? I am aware that we're running out of time, but we allotted time, but it would be fantastic to hear from the director in particular.
Okay, can I come in?
Please do.
Yeah, like in Zambia, it's been on our mind for a long time, but we have a financing strategy in place. Basically, talking about tax revenue, we need an equitable share from National Treasury. But number two, we also think about alternative modalities, like a complementary health insurance program, which have sufficient incentives to attract numbers and be able to like survive or float. We also have had thoughts concerning other sources. Once upon a time, we had the 1% interest from the interest earnings of every bank account. 1% of that would come to the Treasury to finance programs. And at that stage, I could report that, or like our vaccination program could be financed adequately from that arrangement. So yes, but also because the primary health care, we say it's free, but as we go up higher for certain services, there is some cost. So how we manage that and improve its functioning so that for bigger hospitals, which have got cost-intensive programs, we can be able to like subsidize what is coming from government. So that's the thinking around that topic. I submit.
Thank you, Director. So we actually have 4 directors of planning. Also, Dr. Dumisani Shongwe from Eswatini is on the call too. So I wonder if I could just ask Ministry of Health directors if they have any further thoughts, reflections on the value of health financing strategies. No. It sounds like I'm also slightly wary of opening this at this time. It feels that we could do with another webinar and workshop on issues of revenue generation specifically. So maybe this is something we can take to a later call. I think it's clearly a crucial topic about how ministries of health and finance can best interact and support the need for revenues in health sectors. So I don't see any further questions, and we are at the end of our time. So I wonder if I could just hand back to Edward and just to thank all of the to thank the speakers and all of you on the call for your questions. It's really been a fascinating discussion. Thank you.
Yes, thank you very much, Paul. We will now bring this to a close. I know it was getting very lively, and as you rightly say, issues of health financing, I think they attract a lot of interest. Maybe we should consider setting up another webinar on another topic, a specific topic on health financing. But let me thank you all for attending and for your active participation. A big thank you also to our two speakers, Professor Peter Smith and Dr. Takondo Mwase, for your good presentations. And you can actually see how much discussion it has generated. I think these were very good, insightful talks. So I think we'll bring this to a close. But in finishing, let me just say that this is, as I said at the beginning, this is the second webinar in the series. We have a few more upcoming. And I just want to mention here that we have another one on public financial management, which will be held on 9th April. And then we will have another one on evidence to policy partnerships. It will be held within April, but the date has not been set yet. We will communicate when this has been confirmed. We will have another webinar on modeling to inform HIV programs in sub-Saharan Africa. Again, this will be held in April at a date yet to be confirmed. And we have another on ethics and equity. This one has a date. It will be held on 7th May. So we look forward to having you again on the webinar to discuss on these topics. But with this, I thank you once again, and we'll bring the webinar to a close. Thank you very much. See you again in future.